All right, hello everyone. Welcome to today's webinar, Trauma Verification's January Q&A web conference. My name is Alex and I'll be a moderator today. Just wanted to give you a little heads up on the technology we're using today. You'll notice there's a little grab tab menu on the right-hand side of your screen. You can access some features within that menu. If you need to minimize it to focus on the presentation, just click the orange button with the white arrow and that'll drop it to the side of your screen. You can click that again to pop it back out. Now, if you click off of the viewer window and maybe check an email or something and you need to come back to the webinar view, I'll just look at the bottom of your screen and you'll see there's a blue kind of daisy icon there, and if you select that, it should pop the viewer window for our event back up on your monitor. That all being said, I want to mention that the best way to connect into today's audio for best quality would be by calling in by phone, but there is the option to join through your computer's audio as well. All right, well now I'd like to introduce our speaker, Molly Lozada, a Trauma Verification Program Manager. All yours, Molly.
Thank you, Alex. Hi, everyone. Just want to give a brief overview of our team today. Tammy and Julia are out of the office today, but we have Claire in their place, and myself and Rachel Sanchez, the site visit coordinator. Just a few updates for folks who are new to our webinar. For CME, you must attend 15 minutes of this webinar to obtain your CE. An email will be sent to all attendees who qualify for CE within 24 hours of the webinar, ending with instructions on how to obtain those. So if you have any questions, you can email us at thecotvrc@facs.org. The goal for this webinar, again, just a refresher, is to interpret the standards outlined in the Resources for Optimal Care of the Injured Patients manual to ensure that hospitals have an understanding of the criteria to provide quality care to the injured patients. Understand the process and standards involved in an ACS trauma verification site visit and how following these will positively impact the quality of care of the injured patients at your facility. So let's get started. So a couple of things that you'll need on hand are the resources manual. If you don't have a hard copy of the resources manual, you can download a copy in PDF from our website at www.facs.org. Resources here, the link is at the bottom. The PDF copy, just want to iterate that we do not make edits or revisions to that version. The hard copy and the PDF copy are as is. Any changes to the requirements or clarifications for requirements are going to be noted in the clarification documents and the change log that are also available on the resources webpage. Again, just want to state that we do provide monthly updates on these two documents, and if there are no changes to standards or any new clarifications, that would also be noted in the body of the email. I will be sending a news, or I should say a new clarification document in the next week or so. So feel free to share that with anyone I may have left off the list. So here are just a couple of snapshots of what the clarification document looks like. This one obviously is from October. I will certainly coordinate the version based on the month that it's released. This is a copy of the verification change log. If any of you are familiar with the NCDS change log, it's very similar where you can sort based on your level or based on any new changes or a CD or anything that would make it easy for you. You can certainly sort that in any way. It's an Excel worksheet. Recordings of today's webinars will be located on the YouTube channel, and they will be posted within a week of this webinar. I also want to say that there are previous recordings on our webpage, so you can certainly listen to those at your leisure. Disclaimer. All questions are pulled directly from the questions that are submitted. There have been no edits made to the content, so if there's any misspellings or they're not clear, I will certainly do my best to answer them appropriately. If your questions are not answered in today's webinar, it could be that either they need more, I need more information to appropriately respond, or that it's a repetitive question, but we certainly will get back to you within a week of this webinar. A couple of announcements. So the next webinar, as you see here, will be Wednesday, February 22nd, 2017. The deadline to submit your webinar questions will be Friday, February 10th. So if you have any questions that we did not cover here in this webinar today or any previous webinars, please feel free to email us your questions, no matter how long or detailed or short they are. You can certainly send us that, and we'll go ahead and present that. Please make sure you send it to the COT VRC at FACS web address. TQIP announcement for some of you, please go ahead and save the date for the 2017 TQIP Annual Scientific Meeting and Training. The dates are November 13th through the November 11th through the 13th here in Chicago. So go ahead and note that in your calendar, and an email will be sent as the meeting preparations take place. More announcements. Call for data. The next TQIP call for data will open up February 1st. So please submit your fourth quarter of 2016 data, as well as any updates to previous submissions dating back to the third quarter of 2015. The call for data will close on Wednesday, March 1st. Another announcement, and we talked about this at the last webinar, the Stop the Bleed Control, or bleedingcontrol.org website is now available. So you can go ahead and visit the website and just kind of browse through it. And if you have any questions about Stop the Bleed or bleeding control, you can go ahead and email either the COT VRC at FACS.org. So I'm going to go ahead and transition this to Rachel for scheduling reminders.
Good afternoon, everyone. To begin, when you're gearing up for your center site visit, your center site visit application must be received in the ACS office at least 13 to 14 months in advance of your requested time frame or the current expiration date. Since we receive a multitude of applications, having it in this early will basically hold your spot in the time frame you're requesting. So also, in addition, this will provide your center plenty of time to prepare and complete the online PRQ. At this time, all of 2017 and January 2018 has been closed to scheduling, and there's a few slots available February 2018. And you can find the site visit application at the link listed.
So I'm going to interject here a little bit about the Orthopedic Traumatology Leader Form. Again, just a reminder for those trauma centers, for those level 1 trauma centers, whether adult trauma centers or pediatric trauma centers that are planning on submitting an application, be sure to submit the OTL, as we refer to it, OTL form with your application. We ideally want to see it with the application. It just gives us an opportunity to go ahead and send that to our orthopedic liaison for review. So again, the OTL form is just strictly for level 1 or level 1 pediatric trauma centers that are going to have a visit. And the form is located in the site visit, under site visit application. And the website is here, as you will see. It's a little different than the resources one. So for those centers, I just want to clarify, I get the question asked often for the combined centers through the level 1 or a level adult or level 2 or level 1 peds rather, if they each have to submit an OTL form. If you are using different OTL leaders, you do, or if the pediatric trauma center has a transfer agreement in place, we do want you to complete the OTL form, and you would only have to answer questions 1 through 3. For those trauma centers that share the OTL leader, if you want to complete the forms independently, that's okay, but you don't have to. We just ask that if the adult center has their visit first, go ahead and complete the entire form, or if the PEEP has their visit first, go ahead and complete their form. So it's just a little bit of information as how to complete those forms on this slide.
In regards to the PRQ online access, after the VRC office receives your site visit application, the trauma program manager that is listed on the application will receive an email receipt acknowledging that we received your application. And then also very important, right in the body of that email receipt basically is the login for your online PRQ. So you have access to the PRQ right at that point from the beginning. In regards to site visit application payment, we are asking please do not send in payment with your application. And the reason why is because you'll receive an invoice 60 to 90 days before your visit from our office, and which will include the fees for both the site visit and also for TQIP. And then afterwards, your center will be invoiced annually for the quality program fees for the remainder of the verification cycle. And then, of course, this annual fee does not include the fees for additional reviewers. And then you can find the fee structure at the following link. For scheduling the site visits, you should receive your site visit dates by 90 days before your scheduled visit. Sometimes you'll receive it earlier, and on occasion it may be a little bit later. And ideally, all visits will occur during your requested time frame. During scheduling, when a lead reviewer is available for your visit, I'll first contact the trauma program manager to confirm dates will work out. And if you tell me that these dates still work, then I'll secure the rest of the team and send out the confirmation email. So the dates won't be a surprise.
Thank you, Rachel. So we're going to move on to general questions. And generally, these don't tie to a deficiency or a requirement. So a question came in about a new trauma center seeking verification. So there's a couple of slides in here in reference to this. And I do want to let folks know that I will be working on a webinar or a tutorial, if you will, for this exact process. And the question came in asking, how much lead time would you advise for a hospital to prepare to become a level 2 trauma center right out of the gate? Is an ACS consultation visit recommended prior to initial verification visit? Are there consequences if this is not obtained? So first, let me say this will vary for all trauma centers, so it's really a little difficult to answer this straightforward. So I've kind of just given a general consensus, and again, this may be a conversation we may have to have offline, and I'll be happy to do that. So the timeline will vary based on the progress of the trauma center, such as, and again, I'm taking this from this question right out of the gate. To me, that means that there's just a new facility. Again, I don't have a lot of details whether they are admitting trauma patients, seeing trauma patients, or just start-up trauma center. So, so the progress of the trauma center, such as having an infrastructure, resources for staffing, surgeons, specialists, equipment, registry software, trauma data, being in compliance with the standards, etc. So, for example, a center that has been actively functioning as a trauma center for a period of time, again, let's just assume it's 3 years. They may choose to seek a verification visit if they are in compliance with all the standards. For a trauma center that is newly developed, again, probably not seeing any trauma patients or very minimal trauma patients, and just getting started, having some of the infrastructures, it may take up to 3 years or more to fully be functioning and able to pursue verification. Now, the 3 years that I propose here can include a consultation visit. So, again, the question will vary based on where the trauma center is in their progress. So the follow-up question to that was, a consultation visit is not required for verification. The benefit, and I will say this, the benefit of having a consultation visit for any trauma center, whether it's an existing trauma center or a new facility, is really, it's almost gearing the trauma center up for a verification visit. Reviewers often say that during a consultation visit, they're more strict in looking for the trauma center being in compliance with the standards. So, there's a lot of benefits to having a consultation visit, so there's no surprises during a verification visit. So if you have a consultation visit, you exactly know where your trauma center stands with meeting the standards and whether or not you'll be in compliance for an actual verification visit. So, so the short answer is that it's not required, but some centers use it as a mock survey to verification, so it is very beneficial to have a consultation visit. Another question from a new trauma center, please confirm how long a level 3 should be in pursuit of a level 2 trauma status before ACS consultation, then verification. Again, the time frame between a consultation and verification visit will vary based on the progress the trauma center is able to make or demonstrate following a consultation visit. I know there's a lot of trauma centers that try to do this within, I mean, we've had questions come in within 6 months of a consultation visit, and ideally for a new trauma center who's had a consultation visit to be successful, we really want to say it will take a year to 18 months following a consultation visit to actually achieve verification. And there's a lot of things that go into a lot of things to consider when doing this. If it's a trauma center that's had several deficiencies regarding PI or regarding any of the other requirements, the trauma center has to take time to implement those changes and track them and monitor them through the PIPS process to ensure that it's working as it should, or there's no adverse outcomes off of it. If you have a 3-month span in between the two, it doesn't really demonstrate a lot of time for the review team to say whether or not that is actually working for the trauma center. So we do want to see a time frame anywhere from 12 to 18 months. Again, it's not a requirement, but Rachel or myself are going to reach out to you and have a conversation to see where you are in this process. Our goal is for you to be successful, and again, we kind of like to see 18 months, but it's not a requirement, but we also want to, again, be successful in this. Question about, have there been any additional updates to the Q&A document? So I wasn't clear on exactly what they were referring to the Q&A document, but I will say we are currently developing a verification frequently asked question document. There is one currently posted on the website, but that's not what we're looking to do. We are looking to develop one where we have common questions come in, just like I'm doing the webinar. This is going to be an actual document that's going to live in our website, and we will update it continuously for questions that come in. So we are working on that. It's not yet published. The second is we provide monthly updates on the clarification document verification log, as I stated before. And then the third is updated Word versions of the PRQ that match the online versions are now posted on our website on the resources webpage. So any of you that are currently scheduled for a site visit, go ahead, visit our website and download a PRQ that matches your trauma center by level and by patient type. Tiered trauma activations. Question came in about a third level of activation exists. Is that acceptable, and is a 6-hour response time acceptable? It is appropriate to have multiple tiers. It's common to have 3 tiers, as we've seen. We've had the highest activation, the limited tier, and the consult tier. The criteria for the consult tier must be established by the institution, along with the time expectation for the types of injuries the emergency medicine physician or trauma surgeon or advanced practice provider is expected to respond to those injuries. Most importantly, the trauma center has to follow those metrics through their PIPS process. And I do want to state that if you're having your advanced provider respond to your limited tier, they must be current in ATLS. Coordinated report period to site visit date. So the question is, could you review determining the review period or review year date interval related to the scheduled visit date? This can seem tricky if you don't have a clear review date until 60 days prior to the visit. So let me clarify this a little bit, and I know Rachel talked about it a little bit in her, her discussion. The Trauma Center will indicate when you want the ACS to come to review your facility, whether that be for a consultation or for re-verification or for verification. So on the site visit application, you as a trauma facility or a trauma center will tell us within a 2-month time frame when you want the visit scheduled. So the trauma center will then base the reporting period from that time frame with a 2-month lag. For example, I've given some examples here, and this can vary depending on when you are having your visit. The application, if you note on the application that your visit is going to be in March or April of 2018, the reporting period could be any of the following. It could be January 2017 to January 2018 or February 2017 to February 2018. So really just keep in mind that the time frame you give us, just think of a 2-month lag and then start your reporting period or start counting backwards from there. We don't want to see any data older than 14 months coming into your review period. Again, if you have any questions about this, please give Rachel or myself a call. Do the pool cases for verification visit have to come from the review period, or can they be more recent and fall outside that interval period? Yes and no. So if the minimum medical cases cannot be met for the reporting year as listed in the review agenda, if some of you are not familiar with it, you can visit our website here. We ask for a minimum of cases based on categories to be pooled, and they should reflect your reporting year. I say should because if there is a quantity that is not met, you certainly can pool outside of your reporting year if it impacted your PIPS performance process. So if there was a change that came about during your case review and it didn't happen during the reporting year, you certainly are welcome to pull that to demonstrate to reviewers that you had improved your cases or your process based on something or based on a negative impact of your that happened at your facility. Again, you can look at the review agenda for more information on that. For chart categories for an adult center, if pediatric category is included if the center has a separate designation. I know they use that designation, but we don't do that. We do verification. The answer is if the adult trauma center admits pediatric patients, even if you're not seeking a verification in peds, you should pull the category that's noted in the review agenda. There's a small section that asks to pull, I think it's 10 cases for pediatric charts. If the trauma center does not admit pediatric patients and or transfer those pediatric patients to a pediatric trauma center, it is not required to pull those cases. Again, if you're transferring those PEDS cases, make sure you're reviewing those through your PIPS process. Question about EMS feedback, and we've gotten several questions about this and how to deal with this, and I know this is kind of like a trend across a lot of trauma centers. And the question came in, I struggle with certain fire departments for run sheets. I'm wondering if there's a law or rule that I can quote with yet another plea for their compliance. I feel as though I otherwise have no leg to stand on except for nagging, which is time consuming. And I truly understand that. And I will say we don't have a requirement for the run sheets to be submitted. What I can tell this trauma center is that we do have a requirement that says that there must be a representative from the emergency department that participates in the pre-hospital PIPS program. And what I will say to this is that that person can be the trauma center's champion to facilitate the feedback necessary between the EMS agency or the state agency or you know, who you're using for EMS to kind of be the go-between and help you get that information, because as you know, that feedback from EMS is, you know, will ensure continuity of the care for those patients. So there's several ways trauma centers have done this. I've kind of queried a couple of my nurse reviewers, and you know, they're struggling with it as well, or you know, if you have this champion in your trauma center, you know, see if you can get email feedback or get access to an electronic EMS electronic database that you know that maybe is encrypted somehow, and you would just get what information you need for your trauma center. So there's a couple of ways to do this. I'm going to try to get some more information so that I can bring this back to the group for the next webinar. Question about how important is it to be an associate member of the AAAM as a level 3 trauma center? So I will say for verification purposes at any level, it's not just for level 3, for verification it is not a requirement for the registrar or someone in the trauma service to be an associate member of the Association of the Advancement of Automotive Medicine, so AAAM. So we're not requiring you to be an associate member. A couple of questions about the PRQ. About the payer mix, what are we asking for in the payer mix? So for verification, we're asking for all patients seen as an inpatient in outpatient admission. So this will be any patient seen through the ED or direct admit. And again, it's just this does not tie into a requirement or a deficiency. The payer mix is it's just a consensus, and the reviewers just want to see what that payer mix is comprised of. Again, pre-review questionnaire, reporting year. I think this is similar to the one prior. When completing my PRQ for a survey in May, do they want the peer review attendance for my PRQ reporting year? So this is about peer review attendance. Or can I present it as a monitor in a calendar year from January to December? I suppose the same goes for other things we monitor like CME requirements. So for upcoming scheduled visits, the data and documentation must reflect the reporting year. So ideally, for any trauma center having a site visit, any of the data, any of the PI monitoring, attendance for your peer review, with the exception of CME, we want to see it reflecting your reporting year. So the reason I say exception for CME, the liaisons are required to have 3 years of CME leading up to your reporting period, or leading up to your site visit, I'm sorry. Pre-review questionnaire, neurosurgery coverage. Regarding neurosurgical coverage at a level 1 adult, level 2 pediatric trauma center, and this is a combined visit. Section 8, question 11, can coverage response by chief neurosurgical resident be considered an adequate backup to the neurosurgeon attending who may be encumbered if another emergency presents itself? Or is the encumbered neurosurgeon required to have an attending neurosurgeon as a backup contingency plan? So this is going to vary. And the reason I say that is if the trauma medical director and the neurosurgeon liaison have come to an agreement on who is going to respond, whether it be your chief neurosurgical resident or another neurosurgeon or a PA for that matter, if they've agreed to that protocol, that is acceptable. So it is acceptable if they are agreed upon guidelines between the trauma medical director and the neurosurgeon liaison for types of injuries the resident or physician assistant or advanced provider will respond to. There must be clear documentation with the attending specialist surgeon on the plan of care. So there must be some documentation about that. Pre-review questionnaire, FAST exams. Each webinar has had a question about FAST exams, physician credentialing, QI. Is there a CD in the Orange Book? And this person is correct. This comes up at every webinar. And I think it just has to do with the question in the PRQ. We have 3 questions in the PRQ. that are asking who does your FAST exams, how do you QI FAST exams, and who responds to FAST exams. So there's no requirement. Again, it's just more for the reviewers just want to know that information. So we put that in the PRQ. So there are no CDs or requirements regarding FAST exams. Ongoing professional practice evaluation question, could you please elaborate on the TMV responsibility to perform an annual assessment of the trauma panel providers? And does this QI include surgeons and ED practitioners? So yes, I can definitely clarify this. The trauma medical director is responsible for conducting the OPPE for his panel and any mid-level or advanced providers that work for trauma. Now, the TMD is not expected to perform an OPPE on the other specialists such as ED, neuro, ortho, etc. The expectation is that directors for those areas should do their own OPPE for their own panel. So the trauma medical director does not have to do it for everyone. It would just be too much. Nursing education. Is it acceptable to define and design our own trauma nursing education program? Are TNCC, TCAR, et cetera, required for nursing education? And this is due to they're finding it difficult to maintain these programs. So that's a great question. I know I get this asked quite a bit, and so I do want to say training and certification in other programs such as TNCC, TCAR, you know, PELS, etc. They should be available to nurses working in critical care areas or any of the areas that are treating trauma patients. While we don't have a specific nursing requirement for ED or trauma related, the one requirement we do have in the book is regarding that the trauma center must provide a mechanism to offer trauma-related education to nurses involved in trauma. So again, while there's not a specific nursing requirement, you know, the trauma center has to have a mechanism available to offer education to the nurses. This is a great question. I get this often, and I apologize for some of you that were waiting for a response. You know, the question is, why hasn't the ACS or COT mandated a performance improvement coordinator as a requirement for any level, not just necessarily a level 1, but a 2 and a 3, and it goes for PEDS. Currently, we don't have a requirement. You know, that's correct. However, what we just launched, and we're going to launch another email here, is we have a stakeholder public comment website. And in this website, as you see it below, you have an opportunity to comment on any of the requirements that we currently have and provide feedback. And, you know, that way, this would be an opportunity then to implement or mandate for the next iteration of whatever color book it's going to be a PI coordinator, because we know it is very beneficial to have a PI coordinator in your trauma center, so we do know the importance of that. So again, for some of you who have received this email, there's another one that's going to go out for public comment, so go ahead and please take a look at it, and please be, we encourage you to comment on those requirements just so that your trauma center can be successful and be, you know, easier to accomplish success. So we had a question about freestanding ED facilities. Question came in about, I call them satellite facilities. Some people call them freestanding ED facilities. So the question is, what are the requirements for tracking traumas seen at an off-campus ED if the main campus is a level 3 trauma center? This could be for a level 1 or a level 2 as well. If you are a level 3 trauma center and have an off-campus ED, is the off-campus ED included in the re-verification process? Would the off-campus ED data be submitted with the main campus ED data? Do you have any do you have to identify which ED the patient was seen at? So great question. Comes up not as often anymore, but the answer is the freestanding emergency department, or again, off-site campus, is seen as a separate entity from that of the trauma program, meaning that during a consultation visit or re-verification or a verification visit, the facility, this off-site facility, will not be included in the review process. But I will say patients presented to that ED facility will be seen as an inter-facility transfer. So in other words, they're going to be transferred in to your facility, so they will be reported with your data when you do submit that data. So you don't have to identify them any differently other than their inter-facility transfers. Question came in about, can you explain and provide an example of the over-under triage tool utilization for correct implementation? So I've taken this from one of our optimal courses. So over triage, the minimally injured patient taken to the highest level of care, will be 25 to 35% acceptable. Under triage, there is a CD with this. Severely injured patients taken to lower level of care, the optimal goal is less than 5%, and that's CD 3-3, so you can definitely refer to your book for a little bit more information on that. But I will say that one of the things to monitor, we want you to monitor your triage and your activations, whether your highest activation, your limited tier, your consult. And so I just put a table together here, again using a table from the optimal course that refers to the minimum 7. And as you see here, and you can also refer to page 38 in the resources manual, we want you to make sure if you're seeing a high number of over and under triage, you want to go ahead and either eliminate some criteria or add a couple of more criteria, reassess annually, use your registry to drive that data, compare your under and over triage rates to make sure you're in compliance. And again, here's an example of a table, so you can go ahead and view that at your leisure. We're going to move on to CD-related questions. Level 1 volume. So I had a question from level 1 presently who's a level 2 who's considering moving to a level 1. Does the volume of 1,200 admissions need to be sustained for 3 continuous years prior to requesting a level 1 consultation or site visit, or can one request a visit after 1 or 2 years at the 1,200 volume? So it's a little tricky to gauge this because the intent is that the level 1 trauma center must admit at least 1,200 trauma patients yearly or have 240 admissions with an ISS of more than 15 during the reporting year. So as I said in my a couple of previous slides, that your reporting year is a 12-month period, and so during that 12-month period, you have to show that you have admitted 1,200 patients. So it does not, so the reporting year is the time frame leading up to the site visit for either a consultation or verification or re-verification. The volume is not cumulative over the 3 years, so it's 1 year that we're looking for. As a level 3 trauma center, do we need transfer agreements with level 1 facilities that we transfer to on a couple of times a year? The answer is yes. So in a level 1, level 2, or a level 3 trauma center, there must be transfer agreements or a policy, as some people refer to it now, for when patients will be transferred to another institution. Again, even if this is in rare occasions for those level 1s, you still need some transfer/policy agreements in place where required. Do trauma surgeons covering backup calls have to meet the same requirements as surgeons taking trauma call? There are no requirements for the backup call, backup trauma surgeons to meet the CME requirements or the peer review attendance. Again, these are solely your backup call surgeons. Are not required to go ahead and meet those requirements. What is considered active participation for the trauma medical director? So the question is a yearly conference constitute active participation? Yes. Active participation is defined as attending a course or conference. So if, I'll take the East Conference because it just happened. So if you're a trauma medical director, attended and is a member of that organization, that would definitely meet the requirement. Question about limited tier response. Is there a guideline about how long trauma patients, ED length of stay by category, STTA modified consult, or however each org tiers them? I had an inquiry about the need rationale for transfer agreements since EMTALA laws. I think it says since EMTALA law says they should accept them. For the limited tier activation, the time expectation for the types of injuries patients and surgeon will respond to will be determined by the institution. Again, this is for the limited tier. Also applies to your consult level. Most trauma centers choose somewhere between 2 to 6 hours. This is not a line in the sand. This is just an average what trauma centers are using. Obviously, some centers are using a little bit more, like a 12-hour time stamp, but again, you will base this on what your institution sees. The most important thing, I can't stress this, is to follow these metrics through your PIPS process. Do allied health providers, again, your mid-levels, nurse practitioners, physician's assistants, count as a surgeon's response for responding to the lower level activation? It does. It is acceptable for the allied health provider, I'm using that terminology because that's what they use, to respond to the limited or consult tier. For the limited tier, the HAP or the PAs, NPs, mid-levels must be current in ATLS. It is required that there be contact documentation where the allied health provider notifies, discusses here with the attending, and that there is clear expectation that is followed for compliance on admitted patients. So if you're, so I want to say let me clarify this slide a little bit. If you're using your PAs or your mid-level providers for your limited tier, they are expected to be current in ATLS. If you're using them during the consult tier, they're not required to be ATLS. What would be a CD if the board-certified ED physician liaison is not current in ATLS? So I don't have a lot of information from this particular trauma center, so I gave 2 scenarios. In a level 1, 2, 3 trauma center, if the liaison is board-certified in emergency medicine, she or he is required to have successfully completed the ATLS course at least once. If the liaison is board-certified in something other than emergency medicine, such as family practice, internal medicine, pediatrics, whatever that may be, she or he is required to be current in ATLS. So if they're board-certified in emergency medicine, they've only had to take it once. They're board-certified in something other than emergency medicine, they have to be current in ATLS. So I'm being asked for some examples of emergent and non-emergent neurosurgery, or what's acceptable for non-emergent orthopedic and neurosurgery consults. So the liaison for neurosurgery and orthopedic surgery, along with the trauma medical director, will define the emergent and non-emergent criteria and who is acceptable to respond. Again, whether that be a neurosurgeon, orthopedic surgeon, physician assistant, or a resident, you know, that's acceptable as long as it's agreed upon between the trauma medical director and the neurosurgery and orthopedic liaisons or directors. The following slide will provide some examples, and I have had this in a couple of other webinars. So here are some examples of a 30-minute response time for emergent, penetrating injury to head with alternate mental status, TBI with emergent surgical intervention, TBI with emergent EVD monitoring, orthopedic, fracture vascular compromise, complex pelvic injuries with limb life threats, multiple open long bone fracture. So you will determine, you at the trauma center will determine what you would consider emergent and non-emergent. Again, these are just some examples that some trauma centers are using. You don't have to have 3. You can have 1, you can have 2, you can have multiple. So you, again, as a trauma center with your trauma medical director and your liaisons or / directors from ortho or neuro would determine which ones are going to be considered emergent, and go ahead and monitor that for 30-minute response and PI that, PI your response times. Neurosurgery contingency plans. Does a formally arranged contingency plan for neurosurgery backup has to be a second person call. What is the alternative? Again, the alternative would be you either have a mid-level provider respond. You can have a published backup call schedule, as you see here. You can have a diversion plan. Primary and backup neurosurgeons are encumbered. You can notify EMS if you're going to be on diversion. And again, you have to review each of these instances through your PIPS process. So there's a couple of ways to go ahead and do the contingency plan. So backup call schedule or have a process in place where someone else can go ahead and respond like your mid-level providers. More questions about neurosurgery contingency plan. We'll like an example of contingency plan for neuro with credentialing to trauma surgeons. And this is from a level 2, but this can also apply for a level 3. And here's just a snippet and again, this is an example. This is not something that we're asking you to do, but something that you can use and utilize and modify that would meet your trauma center's needs. Again, feel free to use this example that's noted here. Orthopedic complex cases. Must have a level 2 trauma center. Must a level 2 trauma center have a complex ortho capabilities, acetabular, open both pelvic fractures, or can they transfer these patients? And this is for a level 3. There must be protocols for the types and severity of pelvic and acetabular fractures that will be treated at the institution, as well as those that will be transferred out. And these protocols must be part of the PIPS process. For more information on this, refer to the Chapter 9, page 61 in the book. It does kind of outline how that will work at any of these facilities. So you should have protocols in place. So the answer is you should have protocols in place. Board certification for anesthesiologists. Is board certification requirement for all anesthesiologists taking call or just the liaison? Good question. This was a change from the Now Orange book, and we did publish this in the change log and the verification clarification document, so you'll find this in both. Board certification or eligibility for certification, another word for board eligible, is essential for the anesthesiologist liaison who participates in trauma calls. So the change is not for all the anesthesiologist, but we're just asking for the anesthesiologist liaison that participates in trauma call to be board certified. Again, refer to the clarification document or the change log. Operating room backup team, CD 1115, if the first OR is occupied, an adequately staffed additional room must be available. Is there a time requirement? No, there's not a defined time for the second OR room or backup team. The institution will be required to establish a response time and monitor that, monitor the team's response time for any delay through the PIPS process. Interventional procedures. Will it be acceptable for interventional cardiologists and cardiovascular surgeons to perform interventional procedures? Yes, it is acceptable to have those specialists who are trained and skilled in interventional procedures provide that service. Board certification for ICU, I think this is just more of a clarification. The person is asking, or the ICU team may be staffed by critical care physicians from different specialties, but must remain surgically directed as noted in CD 1148. The ICU physicians should all be currently board certified or eligible by the American Board of Surgery according to current requirements in critical care. Noted on page 81 at the top, these are contradictory sentences. Can the ICU physician be different specialty, or do they all need to be certified by the ABS? So let me just say there are two different requirements. The first one stated here, 1149, is referring to the ICU team has to be surgically directed. That means they have to have a physician who, or a surgeon who is boarded, be the lead for the ICU team. So typically the ICU team will be comprised of members from various specialties, so this can be any of the specialties along with residents, but they have to have a trauma attending who is board certified in surgical critical care. Now this is for a level 1 trauma center, not a level 1 pediatric. It changes for that. So they have to be led by someone who is board certified in surgical critical care. The ICU members are required to be board certified by their respective boards. So if you have someone in internal medicine, or if you have someone boarded in something other than trauma or general surgery, they have to be boarded, but are not required to be board certified in critical care. So I think there's just a clarification there. ICU coverage. Does the PIPS program have to have an exact response time of the ICU physician for each time they are called for a critical trauma patient? What level of documentation is required for this? Does 24/7 ICU in-house attending coverage satisfy this? Yes. Appropriately trained physicians must be available in-house within 15 minutes to provide care for the ICU patients 24 hours per day. That's CD 1151. This coverage may be performed by an appropriately supervised senior surgery resident or an in-house trauma attending credentialed to provide critical care. So someone who is credentialed to provide care can meet that requirement. Since there is a response time, it says 15 minutes, there has to be documentation of the trauma attending arrival at bedside. It should be documented in the H&P or in the chart. So however you want to document this, it just needs to be noted so the reviewers can see, so you can demonstrate this to the site reviewers at the time of the visit. So it has to be documented in some form. Other surgical specialists. Is microvascular surgery still a required specialty for level 2 trauma centers? Yes. A level 2 trauma center must have a microvascular surgeon, or coverage may be satisfied by having a surgeon who uses an operating microscope for nerve repair, free tissue transfer, etc. The microvascular capability is not required in-house 24/7, but must have a surgeon consultant available to respond in person when requested by the attending surgeon. So I know early on we had a lot of questions about microvascular and if these can be transferred out. So for any, so if you have a surgeon, so if you don't have a microvascular surgeon per se, but have a surgeon who is skilled in utilizing an operating microscope for free nerve repair, etc., that would definitely suffice and meet the requirement. And then any trauma patients that require acute care treatment, they can be transferred with a transfer agreement. Question about advanced practitioners. This goes to the ATLS. Do all advanced provider PAs need to have ATLS regardless if they participate in activations? Let me clarify that. So if the nurses who are not involved in the trauma team activation, they're not required to be current in ATLS. Those nurses that function as a member of the trauma team activation and are caring for trauma activation patients, such as assessing and providing intervention, they must be current in ATLS. If the trauma and or ED/AP's only role is as a scribe or entering orders, they do not need to meet the ATLS requirement. Again, if they're hands-on, if your nurse providers are hands-on during your high tier and limited tier, they are going to be required to be current in ATLS. Registrar training. ATS recommends at least 2 to 3 years of trauma registry practice before sitting for the CSTR. Why does ACS demand pass within 1 year? So let me clarify this. For verification purposes, we are not asking the registrar to sit for the CSTR. So we're not asking them to be certified specialists in trauma registries. The expectation is for any new hires after July 1st, 2014, they must have attended or previously attended a training course at the time of the site visit, or for any new registrars to your service or to your program, they must have had training within a year of hire. This again is noted on the clarification document. Universal screening interventions. What do you consider appropriately trained staff when talking in reference to CD 18-4? Does expert screening compliance need to be monitored and run by case management, social workers? So similar question, who can do the screening? We don't have a requirement that it has to be a case management or a social worker per se. You know, the requirement is really loose, and it says appropriately trained staff must conduct the expert. So it refers to should be someone with training and intervention. So someone trained in expert will suffice. So if your PI coordinator, your injury prevention coordinator, or your case manager or social worker is trained in experts, that will definitely meet the requirements. So the next couple of slides are going to refer to CME. We can't do a webinar without talking about CME. And what exactly is trauma-related CME? So good question, and hopefully I will clarify with this. Trauma-related CME is defined as attending a course online or in person or national regional conference that are relevant to the management of a trauma patient and their care. So this is referring to, actually it's referring to any any courses or any national conferences, regional conferences that, you know, your physicians have attended and received a certificate for attending. So it's continuing medical education is what we're looking for trauma-related. So it has trauma-related, it has to be relevant to the management of the trauma patient and their care. Internal education. Can attendance at grand rounds presentations of a trauma-related topic be counted for CME? Do journal club discussions of trauma topics count for external or internal CME? So anything related to grand rounds or trauma-related topics, they're going to count as internal education process or internal CME. They're different than external CME, and you can find this exact language in all of the chapters in the resources book. So as mentioned in the previous slide, external trauma-related CME is defined as attending in person a course online, in person, or national regional conference that are relevant to the management of a trauma patient and their care. So acceptable internal education process can include any of these activities: in-service lectures, educational conferences, meaning if your physician, surgeon went to a conference and brought back information and wanted to have that as peer review or disseminate that within the group for educational purposes, that certainly can count as an internal process. Grand rounds, internal trauma symposium or in-house publications, and dissemination of information gained from a conference, as I just stated. Total hours, we're asking the total hours acquired through IEP, internal education process, should be functionally equivalent to 16 hours of CME. Again, this is stated throughout the book and each of the specialty sections. Pediatric CME, why do we need to track CD 1029 if all physicians need pediatric trauma CME? And this is, I'm going to assume that this is coming from a level 2 pediatric trauma center. If not, please correct me and reach out to me through the DOT VRC inbox. CD 1029 is different than CD 1024. 1029 is referring to the trauma center providing pediatric-specific education to non-trained pediatric specialists, such as anesthesiology and possibly emergency medicine. I'm going to exclude neuro and ortho because in the next requirement they have to have pediatric CME. So if this is a level 2 pediatric trauma center asking this question, CD 1040 is what you want to focus on. So the CD 1040 quantifies the number of external trauma-related CMEs required for panel members, such as your general surgeons, orthopedics, neurosurgeon, emergency medicine, critical care. This may be met by having 16 hours of CME per year on average, or by internal education process. This is not for your liaisons, but this is for your other panel members. So there's a difference between 1029 and 1040, again, if this is for a level 2 pediatric trauma center. CME for emergency medicine. This is a great question. ACS offers up to 90 CMEs for CSAP, which is true. Can trauma surgeons use any or all of these CMEs? And then there's a follow-up question for new ED physicians that just completed residency. Are they required to have CMEs? I do want to clarify that CSAP only awards 6 hours of external trauma-related CME. If this is what we know, if additional CMEs could be attributed to the care of trauma patients, we certainly can will take that into consideration. But we are aware that it will allow 6 hours of trauma-related CME. For new physicians, surgeons who have just completed residency, they are required to have CMEs. However, if they are new to the service within the reporting year, their CMEs will be prorated. For example, if they were just there shy of 4 months leading up to your site visit, you certainly can prorate their CMEs. CSAP and internal education process. How many trauma-related CMEs can we give our physicians for taking CSAP in addition to the trauma specified? Again, as I stated in the previous slide, we will award 6 hours of external CME. And the follow-up question to that was credit for attending their trauma M&M. Is it acceptable to give them CME? You can for internal. You can't do it for external trauma-related CME, but certainly credit for attending the trauma M&M may be awarded to meet the internal education process. ICU CME, do non-liaisons, ICU providers that potentially take care of trauma patients need CME? Yes. Providers used to provide coverage for trauma patients in the ICU are expected to meet the same standards as the other surgeons participate in internal education program that is case-based learning or obtain 16 hours of external trauma-related CME. Alternate at peer review. Great question. Again, this is clarified in the clarification document and the change log. So liaisons to the trauma program, emergency medicine, neuro, ortho, critical care have to have external CMEs. I've answered a couple of those questions on the previous slides. The ACS now allows one alternate person to attend a multidisciplinary peer review meeting when the liaison is not available to attend the meeting. Does this alternate person have to have external CME? No. So let me say for the peer review meeting, the noted alternates, as you noted above, are required to meet either the external trauma-related CME or the internal education process. So they can meet one or the other. And that now concludes our webinar session. And I'd like to say thank you for attending today's webinar. I know it's a little long today, but again, I greatly appreciate your participation.
Awesome. Thank you, Trauma Verification staff, and thank you everyone for attending today's webinar, Trauma Verification's January Q&A web conference. If you have any other questions, feel free to contact cotvRC@facs.org. And on behalf of Trauma Verification and our presenters, thank you all for joining us today, and have a wonderful rest of your day. Cheers.